and we've gone live. So good afternoon. Thank you very much for coming to this session. My name is Donald McIntyre, and I'm introducing Professor Inez Myin Germeys. She's a psychologist and professor of contextual psychiatry in Belgium, and she's head of the Center for Contextual Psychiatry, which she founded in 2015. She's a world expert in the field of experience sampling and mobile health in relation to psychopathology and particularly psychosis. She's published over 370 papers and supervised over 30 PhD projects. Now, her title, Digital Health, Can It Bring True Person-Centered Care in Psychiatry, is of particular interest to me. In Scotland, both our national medical and our mental health strategies have the stated aim of person-centered care. But there are actually quite a few conditions where individual treatment outcomes can be predicted, and there's a lot of empirical treatment or trial and error used in clinical practice. This reveals the limitations of our current diagnostic frameworks, and something that we're very aware of, particularly in psychiatry. Many attempts have been made to refine diagnostic categories to improve the predictive power of diagnosis over the last 100 years. So this is an area of profound unmet need, but it's also an enormous challenge, and it requires innovative approaches. So I'm very excited to hear what Inez has to say. Thank you very much.
Thank you. And it's a real pleasure to be here. And of course, I really regret that there is no opportunity to actually be live there with you. That was what we were hoping for. But still, I'm very pleased that you have me then via this digital channel. So indeed, today I want to talk about digital health and how it can bring true person-centered care in psychiatry. Next slide, please. So I want to talk about, or I will share with you two different things that we can do with the digital technology. Next. And I want to start first with sharing some very fresh and new data on a blended care approach. And then I will move more to person-centered care. So next slide, please. So I want to talk about blended care in the form of ecological momentary interventions in psychiatry. An ecological momentary intervention is basically aimed at sort of transferring the psychological intervention to the real life using digital technology. So basically, yeah, next, what we're trying to do is deliver therapy in the real world. Next. At moments when it's most needed. So that's interesting that with mobile digital health, you can actually provide interventions at moments when people are most in distress, for example. Next. It also, of course, offers sort of round-the-clock support because people have their phones with them, so they have access to them whenever they need it. Next. And most importantly, we hope that by bringing this to the real life, that you can maybe start to induce sustainable change, that it's helpful in terms of skills, training, and development. Next, please. So what I want to talk about today is our Interact study, which we started based on my ERC grant already in 2012, so it takes a long time to develop this. And this is a trial that we did on acceptance and commitment therapy in daily life. And so basically, we compared an acceptance and commitment therapy in daily life with 2 control groups, control CBT and a treatment as usual group. We had pre and post measurements, and we looked at distress functioning, and we looked at also follow-up outcomes at 6 and 12 months. Next. Basically, we ended the study with about 150 participants, and we had 71 people with at-risk mental state and a first episode of psychosis in the active treatment group, and an equal number in the control conditions. Next. Next, please. Yes, thank you. Next. So what did we basically do? We wanted to bring acceptance and commitment therapy to daily life. So people had 8 live sessions with their therapist. Next, please. So during these sessions, this was a one-to-one, face-to-face personal session with a therapist. Next. In between, yes, next. In between these 8 or 7 sessions with the therapist, people got the Act in Daily Life app on their phone, and they did exercises related to what was being discussed in the therapy in their normal daily life. Next, please. So they get some, for example, we were giving them a metaphor, or we were giving them an exercise, and they were also, of course, rating themselves, sort of bringing them back in that moment and really looking at how they were feeling at that particular moment. Next. Next. Then in the final weeks, we also looked at personal values. We asked them what they wanted to work on, and then that was also encouraged using the app. Yes, next, please. And then we also had additional action exercises, so people could always go back and do the exercises whenever they wanted. So this whole idea is that you really have a face-to-face therapy, but that you use an app to really practice it regularly on a regular basis in daily life with all sorts of experiences that you have at that particular moment. Next. I will now discuss a little bit of, is this really feasible? Do people want to do that? And then I will go to the outcome of this specific study. Yes, next. So first of all, adherence. When we look at treatment adherence in number of sessions, yes, next, please. We see that 60% of the participants took part in all face-to-face sessions. So this is people attending 0, 1, 2, 3, 4, 5, etc. So you see that most people attended all the sessions. Yes, next. You also see that they kept using the app over all these weeks. Yes, next. And we had an average of 6 face-to-face sessions that people attended. Next, please. Then when we look at the number of interactions with the app, these are the 7 consecutive weeks, we see that people on average had 12 to 14 interactions with the app in the week following the intervention. Yes, please. However, although that may seem quite a lot, that means that the overall compliance rate was only 25%, because we asked them to do exercises and fill out beeps more often than that. When we looked at, of course, in this group are also very non-compliant participants. So if we look at compliant participant, that number goes up to 50%. Next, please. When we look at acceptability, how people felt about this, yes, you can see that on the one hand, that people say that the app, that they found it useful. And sorry, I now have to go very close to my screen because it's very small. They also said it helped them implement the exercises. So you see that in terms of acceptability, then that number was quite high. Yes, next, please. However, it also felt like a burden. People felt like, here you see that the number of people saying, or that a lot of people say the number of beeps and the number of questions they had to report in their daily life was burdensome. Next, please. Still, if we look at this, we see that most of these people, when you look at the darker green colors, you see that people say that they used the app, the sessions, and the workbook that was the most helpful components to them. So overall, it feels like helpful to them. Yes, next. And they also say that they definitely that they think they will continue to use the exercises in their daily life. So that says something about sustainability and about that skills build-up. So the question is then, okay, this is nice, but does it also really help? And in order to look at that, we have done both a qualitative study and we did the randomized clinical trial. The qualitative study we're still working on, but when we look at some of the quotes that we get from participants, we see things such as, yes, next please. It's the first thing that really helped me. I very strongly believe my thoughts, but that has come down. The app is helpful because it brings you constantly back. Remember your exercises, your breathing, what do I feel? The app created awareness about what I was doing and what I felt. Yes, next. But people also say, I did not like the beeps every hour. It irritated me. The questionnaire was very long. That was annoying. And the same questions came back over and over again. So people felt that it was helpful, but they also had some comments. Now, when we look at efficacy, does this work? First of all, so our primary outcome was psychotic distress as measured with the CARMS. Now, I will show you a number of graphs, and each time you see pre-post 6-month and 12-month follow-up. The lighter blue is the treatment as usual, and then compared to the ACT in daily life in the darker color. So what you see here is that overall psychotic distress is going down quite a lot, but not different in our treatment compared to CBT or the other control conditions, so both control conditions. So in that sense, we were not doing worse, but we were not doing better either. Next slide, please. However, when we look at social functioning, both measured with self-reported social functioning, the SFS, and global functioning measured with the SOFAS, you see that at post-treatment, but also at 6-month follow-up, and for the SOFAs also at 12-month follow-up, you see a much stronger improvement in our ACT in daily life group versus the control condition. And mind you, the control condition was a mixture of very active intervention, including CBT, and also treatment as usual. So that was quite interesting that the functioning in itself clearly improved over time, and also that it remained over time. Next slide, please. When we look at BPRS scores, symptom scores, we see only a limited effect. So overall, when you look in the right corner, down corner, you see the positive symptoms of psychosis. There you see again that there is a reduction, but that it's not better in our treatment versus the control condition. And overall, I don't think there's a lot of effect on the symptoms specifically measured with BPRS. Again, however, when we looked at negative symptoms, next slide, similar to the functioning, we see an improvement of our ACT in daily life. However, I think what you basically see here is that in the other conditions, negative symptoms actually deteriorate over time, whereas you see with our intervention, they actually improve over time. And I think that nicely fits with the findings we had on the social functioning as well. I have to say, these are, it's the first time I share this data. These are very, very fresh results. We are still, they're also still preliminary. We're still controlling for some issues, but overall, this seems to be a steady finding, and actually a very interesting finding of this mobile health intervention. Next one. So basically, what we found is that adherence is reasonable, while acceptability seems to be good. People seem to be happy to do this. However, participants also felt that it was too burdensome. We had no significant interaction effect on our primary outcome, which was psychotic distress. However, we found that it did improve functioning more than treatment as usual, including CBT. And also there was a significant improvement in negative symptoms. Next. So basically, I think this really is one of is an interesting study to show some evidence for this extra value of mHealth approaches, and especially also the value it has on this daily life processes or daily life patterns, keeping people active and keeping people focused on what's important to them in their normal daily life. Yes. However, it was also clear that improvement is really needed because it also had some downsides. So yes, next please. What we're currently doing is we moved from the Interact study to the Impact study. Yes, next. And what we're currently doing is optimizing the app for the clinic. So we have taken into account all the comments that we got from all the different stakeholders, including the clinicians who worked with it, but also the service users who used the app. And we're currently adapting it. For example, we are reducing the number of interactions that they will have with the app because people felt that that was too burdensome. But we also made it more flexible so that it can be more easily applied to the clinical practice or to the routine mental health care as it's normally used. Yes, next. We're also preparing official trainers manuals so that we can really distribute this. Yes. And we're currently running an implementation pilot. Yes. And of course, we're also working on medical device regulation and a business model. But I think what the main message is of this study is, on the one hand, that it's really, really important to look at efficacy and efficiency. Does it work? And effectiveness, does it work? But also at implementation, does it work in the clinical practices where we want to use it? And how does it actually align with the needs of those clinical services? Next. So I think if you look at the research that is available in terms of mobile health, I think the implementation research is one of the things that is often lacking. So you see that there's a lot of new apps are being developed and are being used in a study, for example, but then creating the next steps of actually implementing it seems to be much harder. So that's one of the things that we're trying to do here. Next, please. So then let's go to the next step, yes, which is then person-centered care. So how can we actually use mobile technology to come to a person-centered care? Yes, next. And so in the second part of my talk, I want to discuss that in a little bit more detail. And so I want to start with the experience sampling methodology. So basically, what is experience sampling? We ask people, we give people an app that signals them several times a day during a number of days at random moments. And then we ask people questions about their current situation. What are they doing at that moment? Where are they? Whom are they with? But of course, also their current mood, symptoms, etc. So it gives you sort of random sampling of self-reports of people's mental states. It has been around for a very long time, and it's mainly been used as a research instrument. And for the last 10 years, I would say, it's been sort of promoted as something that would be very, very helpful in the clinic, but somehow it's very hard to get it to the clinic. And so this is what I want to discuss in the next minutes. Next slide, please. So the idea is to develop a digital mobile mental health device. Yes. And so what we want to do is not only ask people to self-report in their normal daily life about all these things, but then also next have a platform where both service users and clinicians can look at the patterns of behavior and can also try to bring them together. So what was the average mood over the last week? How is that related to certain contexts, etc., etc. Yes, next slide. And that, I think, will bring us to a person-centered care, and I will give some arguments for that in the next slides. This is actually what I'm currently presenting is the goal of the Immerse consortium, and Immerse is a consortium of people working together to bring this application to the clinic. And it was just last week founded was granted money by Horizon 2020. I'm very happy to say that the University of Edinburgh in Scotland and a lot of partners within Scotland are also part of this consortium. So the idea is basically that we do an implementation study of this approach so that we're not only developing the science, but also at the same time make sure that it actually gets to the clinic where it's actually needed. Yes, next one. So how does it work, or how is it helpful for this person-centered care in psychiatry? So basically, what we claim is that it will help both service users and clinicians. So for service users, yes, we think it's an important tool for empowerment and engagement. Yes, next one. So, well, maybe before I discuss this particular figure, so it's important for empowerment and engagement because people really become active partners in the process. Service users are not only they're experts of their own experiences, but by providing them with a tool or by giving them the digital mobile mental health, we give them a tool to bring that expertise to the table and to actually have data or something to share with their clinician. And it's really important because we see that, for example, and now I turn to the figure, that things such as hallucinations, yes, next slide, please, and delusions can quickly, can vary extensively from moment to moment. So understanding this pattern of changing or understanding this variability and also understanding what drives these variations can be very important for people to understand what is actually happened. Yes, next one. Yes, next one. Sorry, yeah. And for example, in the so when I speak about understand what's actually happening, for example, we also know that is very individually determined. So just to give you a short example, so we found, for example, in a big group of people with psychosis or with paranoia, that an increase in anxiety and a decrease in self-esteem, and this is an odds ratio, the one, that is predictive of being more paranoid the next moment. However, when we look at each of these individuals separately, we see an entirely different pattern. So for some people, anxiety preceded paranoia. For other people, paranoia preceded anxiety. And for other people, paranoia actually decreased anxiety. And for a number of people, we couldn't look at an association because there was no variability in one of the variables. So what this tells us is that this is really personal and really individualized. So even if we can find this at group level, that doesn't translate to each individual patient. And what we can do with experience sampling is actually look at these patterns for each individual service user. And in that sense, it is really a tool for people to get actively engaged with their own treatment. Next slide. Next, yeah. But it's also important for self-management and recovery because you really give people a tool to work with their own problems. And this is an example that I want to show from another study that I was involved with, where people with depression actually were giving this kind of feedback. So they were doing experience sampling, and then they were given feedback, for example, on the association between the type of activities they were involved in and how that related to positive affect. And so in this example, you can see that active relaxation is related with most positive affect. You see that on the left-hand side. But in the on the right-hand side, you see that the dark blue piece of the cake is active relaxation. So it's a very small part of the pie. So they only do that in a very limited number of moments. So there are moments when people with depression still feel positive affect, but they don't seek out that context very often. And by just making people aware of that, yes, next slide, we found that that there was a clear decrease in their depressive symptoms. So if you look at these three conditions, the upper condition is the control condition which was treatment as usual. So over time, you see on the x-axis is the line over time. So you see that people stay as depressed as they were from the beginning. The red line, is the pseudo intervention where people did experience sampling, but they were not provided the feedback. So they just did it. And while they were doing it, so just post-treatment and shortly after stopping the intervention, it had an effect, it improved. So just being more aware of your emotions and what you're doing has an effect, but then it didn't last over time. And by providing people with the feedback, we actually very interestingly saw that they improved and also that they kept improving over time. So even up to 24 weeks after intervention, we still saw an improvement. So something changed. They did change something which clearly affected their depressive state. And I think that is actually also nicely reflected in the study, the Interact study that I just showed you, which is where also the social functioning actually over time kept improving. But this is a really nice example of how it can help people to change things themselves and to work on their self-management. Yes, next slide, please. Next slide, please. Yes, next one. But of course, it's also important for clinicians. And I think basically what I just discussed can be reflected on that. So when we give that personalized feedback, when you have when people do this individually and you look at all these different patterns, you can, as a clinician, I think, identify better what is relevant to you, what are the personalized target for treatments, and how can we use that. But also, and I think this is equally important, I think this is an important tool for shared decision making. Not only to come to a joint decision on what are the important targets and where do we need to work on, but also because with this tool, it's not just about assessing symptoms or assessing problems, but it's also looking over time on how is your daily life influenced and how is that changing over time. So it can be an important shared decision-making instrument to decide what to intervene on and how to intervene, but also to evaluate interventions and to see, okay, we started an intervention, so how does this impact your life, both positively and negatively? And so I think what is really lacking often for shared decision-making is good quality data that people can share with one another. And I think this, with this instrument, we actually can provide that really detailed, good quality data that clinicians can discuss with the service users to actually come to a shared decision at different stages in their treatment. Next one. So I think that basically this sort of intervention puts the individual at the heart of their treatment. People provide their own data. They provide a self-report of how they're doing and so on, what their patterns of behavior are. And this makes them a very active partner in the process. I think what we're also trying to do with DMMH is not just work on technology, but actually work on a technology-enabled service. We want to see how this technology can actually improve the clinical services that we offer. We want to make this a responsible innovation, so that means that we will very closely work together with all the relevant stakeholders. But also that really we need implementation studies. It's not just about developing something, it's about seeing how do we get it really into the clinic. Yes, next one. So that is actually then the goal of the eMERGE project. And this is, as I said, we just received the news 2 weeks ago that this is funded. So this is what we're trying to do over the next 4 years. We will try to transfer this instrument to routine mental health care in close collaboration with all the relevant stakeholders, including clinicians, service users, but also hospital management, technology, the technological services, etc. We also want to create still more innovation, so we're including a machine learning work package, where actually what we're trying to do with the machine learning is not to, in the wild, identify patterns that may be relevant, but actually we want to help clinicians and service users by pushing forward patterns that seems most relevant for this individual. So that you, of course, will have access to all this information, but some things will be more relevant for you than others. And so we want to use machine learning to push forward the most relevant patterns for that individual person. We will evaluate implementation at 8 sites in 4 countries, and we will really work on overcoming barriers for implementation, looking at technical barriers, legal barriers, ethical and policy challenges. And I think this is really important because I think there's so much possibilities in this mobile health developments. Still, the clinical uptake is relatively low, and I think that is because there are so many barriers around still, and you really need a whole consortium with very different expertises to overcome them. Next slide. Yes. So that already brings me to the end of my talk. So I think that a mobile technology is helpful both as blended care, so to bring therapy to the psychological interventions to the real life of people, but also to help create a person-centered care which is really focused on the individual needs and of that specific person. I think overall all these developments need to be done in very close collaboration with stakeholders. There's no need in developing something that either people don't want to use, that doesn't fit the standard clinical practices, or that is technically simply not possible to integrate. So we need close collaboration with stakeholders, yes. And of course, we also need to shift focus to implementation studies. I think there's already a lot of things out there, and it's really time to bring them to the clinic, yeah. But of course, we also need evidence of efficacy and efficiency. So also the Immerse project will include a trial, yeah. And then we can transfer it to the clinic. And I think if we are able to do that, yes, next one, that will bring us to a true person-centered care in psychiatry. And that brings me to the end of my talk. There's one other lesson that I want to share when I was making this presentation. If you want to be successful in grants, you best start them with an I, because apparently that seems to work: interact, impact, and immerse. And of course, this is not just my work. This is these are the people that I collaborate with in the Center for Contextual Psychiatry. And I mentioned the people of Interact here, but of course, I definitely also want to mention all the people that will work on the Immerse Consortium. We are very, very excited. And so I'm really, really happy that we have Scotland on board as well. It's a very exciting endeavor, and hopefully in a few years we can share with you whether it was successful. Thank you very much.
Thank you. Thank you very much. Well, that was a fantastic talk. That was a tour de force. And I was very impressed by the kind of the sustained improvements that you were able to demonstrate in your first set of studies. And it was fantastic to see the kind of insight-driven benefits of the second set of research. And it's a kind of insight into behavior rather than insight into psychological processes, which perhaps seems to be, maybe the secret sauce in a way of that, of that methodology. So that's very, very, very interesting. And of course, absolutely delighted and congratulations on your being awarded that grant. I'm sure I would speak for my colleagues in Edinburgh to say we're fantastic to help you out with the project. We do have a good track record of implementation of technology-enabled care in Scotland. We had a computerized CBT project, which has been fully implemented across the whole of Scotland, and we had over 20,000 patients treated last year. So hopefully we can scale up, and we can help you do that.
Yeah, we count on you, because we see Scotland as sort of the flagship country where you're way ahead of the curve, and Belgium definitely way further than Belgium or Germany for that matter. So we're very excited to collaborate.
Thanks for the compliment. So I'm turning to the chat box. I can see one question from Andrew Gumley. I don't know if you can see it as well in this, but it says, what scope is there to bring statistical analyses to data collected in the context of experience sampling methods delivered to therapists and service users, for example, network analyses?
Oh, sorry. I was trying to find the chat, but I don't think I have access. So could you repeat it one? Sorry.
Yeah. So what scope is there to bring statistical analyses to data collected in the context of ESM delivered to therapists and service users?
Yeah, I think that is, of course, a very important question. And that is also, I think, where we still need to develop further. But I also have to say that we take a very careful approach in terms of statistical analyses. For example, with these network models, as was also, I think, part of the question, I'm very, very careful about that because, for example, in terms of network models, there has been a study done, which is, I think, just published recently, where they have sent a data set of one individual to 9 different groups that run these network models, and they all came up with something different. They all had a different model, and so it does show that we're still at the beginning of that. And I think these are all very interesting, interesting investigations. But once we use it in the clinic, we have to make sure that what we show actually makes sense. And at this point, I don't think that we're at a stage where like a network model may seem attractive, but then people take that very seriously. They will actually start to target their treatment based on what comes out of the model. Whereas as I said, 9 different groups create 9 different models based on the same data set. So this is not ready for clinical implementation. So we take, in that sense, a conservative approach. Although, of course, we need to make advancements, and I think the more I'm very keen to see what will come out, and we're also working very hard on further statistical developments. But when you use it in the clinic, we need to be conservative. So in order to make sure that what we show makes sense.
Very, very wise. We started a bit late because of technical issues. I think we really have to try and squeeze in one more question before Andrew is going to make his closing remarks. So Alison Howard has posted a question, and she says, thanks for a very informative presentation. Earlier, we heard about the different responses to digital tools that occur in different age ranges. That is, younger individuals respond more positively to the use of digital tools. With this in mind, do you think different tools would need to exist for specific demographics within the population?
I think that is a very important question, and also one of the things that we will try to tackle within the Immerse project, because that is, of course, also part of the implementation, is looking at who actually can use this technology, wants to use this technology, and how does that work in different populations. And it can be different in terms of tech savvy, that can be different in terms of age, that can be maybe related to their mental health problems that they have. What we do see, though, is that because there's quite a bit of studies on that over time it's getting more and more accessible to people. So I think that the group of people that we are targeting in terms of, for example, the studies that I showed in psychosis, these are age ranges where this works actually really well. But still, it's a very important issue that we only just started to investigate, actually. So it's really something to take into account. I fully agree with that.
Yes, we need a range of options, don't we, for to be able to
absolutely, and that is, I think, also the goal is to expand that range. And provide more options. Not everyone will. It won't work for everyone, and also it's putting the person in the center of their own treatment will work very well for a lot of people, but for some people, it's not for everyone, exactly. But that's the goal, I think, expand our range of options, because we need more options than we have now.
Yeah, that's fantastic, wonderful. talk, great questions. So I think we should wrap up this this presentation and allow Andrew to wrap up the day. So
all right. Thank you very much.
Thank you. Fantastic.
So I think I'm live. What a wonderful day it's been. And thank you very much to everybody really for your participation in the day. You'll be glad to know that my closing remarks will be brief. And one of the great pleasures I have is to announce the poster prize winners. Before I do that, I'd just like to make sure that I say thank you very much to all of our plenary speakers today, Inez, Danny, Matt and Chris, all who provided truly excellent presentations, thought-provoking, and doing such important work for how we translate research and how we translate science into practice now and during these times. So thank you very much to our speakers. I'd also like to thank our parallel session speakers as well, and apologize to them because I jumped between the sessions quite a lot so I could make the most of both. So really a special thanks to Breda for bringing together the session on the challenges and opportunities of data science and mental health, and to Susie for bringing the session together on PPI and really talking about the work that we've been doing over the last year. It's just been really excellent. And thank you to our poster presenters as well. We had 27 posters and they were all exceedingly high quality. And Ashley and I were had the pleasure and the challenge of judging the posters, and it was a challenge, and we appropriately declared our conflicts of interest. So we have come up with some winners of our poster challenge. So I'm going to first of all announce the winners of our poster competition before I announce the winners of our people's vote. So our first, and I should say that Kathy Deeth will be in contact with our poster winners, and all of them will win a £50 Amazon book voucher. Our first winner for her poster, which described a systematic review of neuropsychiatric and cognitive assessments in clinical trials for for ALS, is Emily Beswick. She did a fantastic poster and a fantastic presentation. So congratulations to Emily, and she did a much better poster than I tried to pronounce there. Our second poster winner today was for her poster describing the causal effects of transition into poverty on mental health in the UK working age population. So congratulations to Rachel Thompson for winning our poster prize. It was a really excellent poster, so thank you for an excellent poster and excellent presentation. So our People's Choice winners this year are, so we divided this into a morning winner and then an afternoon winner. So for our morning winner, the person who received the most votes, and I'm very pleased that she did, was for her poster entitled The Role of Human Pet Attachment on People's Mental Health and Wellbeing Over Time During COVID-19 Lockdown. So congratulations to Roxanne Hawkins. And this year for our afternoon, we actually had a tie for Best Poster, and after a brief deliberation, we've agreed that both of these poster winners will also receive a £50 voucher. So the first person I'd like to congratulate is for her poster describing exploring changes in body image, eating and exercise during the COVID-19 lockdown, a UK survey, is Mackenzie Robertson. So congratulations, Mackenzie. And our final winner for her poster on what do service users think about being asked about their mental health every day, And what can such intensive data collection tell us about fear of relapse and psychosis? So congratulations to Stephanie Allen for our second afternoon poster winner. And the standards were just really, really high. And thank you to all our poster presentations for joining us today and presenting their posters. And we really appreciate it. Just some final thanks I'd like to say. So conferences don't grow up by themselves. They grew up in a community, and it was a community of people who brought up this particular conference. And I want to say particular thanks to the Mental Health Network Management Board. So special thanks to Ashley, Justin, Michael, Catherine and Lisa. Also thanks to all our staff across the network, Emma and Kimberly, Catherine O'Hare, Louise Beattie, Claire Matrinola and Susie Sirrett too. Also, thank you very much to our particular thanks to our PPI collective, and it was really good to see George McMeekin here today. And I want to say that we missed Chris Wright, who from the Mental Health Foundation, who was unable to join us today, but has been such an important part of our PPI. And I want to thank you as delegates for joining today and making the day such an excellent and such a what feels like a successful day and a good way forward for us to do more events like this. If you have suggestions for events in the future or for topics that you'd like us to consider and cover, please do get in contact with us, and please do go to the website, download our evaluation form, and tell us what you thought of the conference. We'd really, really like to hear from you. We'd really like to hear about the kind of topics that you'd like us to pursue at next year's ASM in 2021, or if there are other kinds of events that you feel would be really good to organize or to facilitate across our network. So that's it from me. On behalf of the whole team in the NRS, thank you for coming along today, and wish you a very happy and restful rest of the day, and thank you for joining us.